this webinar, and we have started that recording just now. Okay, let's move on then. So the background to this is really just to set the scene, and you will all be familiar with, I think, what had become routine practice in many centres, the practice of doing a urinalysis on the urine of patients or residents who were newly admitted, newly transferred to a residential care facility, and also at regular intervals, perhaps on a monthly or quarterly basis, which I think had become well established and kind of routine practice. I suppose the other reason people were doing it was when they were suspecting urinary tract infections. And so today we're going to take you through a little bit about why and how our thinking has evolved in this area, to explain why we're trying to move away from this, what had become established practice. I suppose the first thing to say is that it's well known now that older persons, as we age, as all of us age, and therefore the people that are cared for in these settings are more likely than younger persons to have bacteria in their urine. So that a dipstick urinalysis done on a person's urine is more likely to be positive, regardless of whether they have an infection or not. So it's not a helpful test to help you decide if someone has a urinary tract infection. And that's really what we'll be talking about today. And the other thing to say is that when the normal defenses of the urinary tract are breached, which is what happens when there's a urinary catheter in place, this is also likely to be the case. So it's with the longer a urinary catheter is in place in any given person, the increased chance of their urine testing positive on a dipstick urinalysis, giving clues that to date people might have considered represented infection, but really are representing bacteria in that environment. So if the person who's been tested or whose urine has been tested has no urinary symptoms, those bacteria are not doing any harm. So they're detected, they're certainly there, no one's saying they're not there, but they're not doing any harm. And the harm comes then when those people are given antibiotics because they have a positive dipstick, because we know that antibiotics are not a harm-free option. Not alone do they have consequences like other medicines have consequences on the individual, but they may have consequences for other people too, in terms of antibiotic resistance. But for the individual, they do have harm, and we'll come a little bit to what those harms might be.
Okay, Emer, I might come in here.
Yeah, I'll hand over to you, Mary. Thank you.
Thank you. So hi everyone, Mary Philbin here. So I'm going to talk a little bit about what we have found in the older persons residential care facilities within the HSE, because I'm very conscious we have colleagues from both the HSE and from the private facilities on the call, and you're all very welcome. So the antimicrobial pharmacists in the CHOs did fantastic audit work in defining baseline antibiotic use within these facilities, and as part of that they looked at the dipstick use. So in that study that was carried out in 2020-2021, they found that 42% of the facilities performed dipstick urinalysis on every resident, be it on admission or every few months, regardless of whether they had signs or symptoms of a UTI or not. 56% of facilities perform dipstick urinalysis when the resident has signs or symptoms of infection. And I think it's very important to call out that actually 2 facilities in CHO 7 reported rare use of dipsticks. So we would like to congratulate them on getting to that point. And I think it's really important to call out that actually they were among the lowest users of antibiotics within the audit. So I suppose, again, we don't have definite reasons as to the relationship there, but I think you can see that probably the overuse of dipsticks can lead to the overuse of unnecessary antibiotics. And when the audit was pulled together and the report prepared, there were 5 key recommendations, and one of those key recommendations coming out of that report was that the practice of routine use of dipstick urinalysis for those residents that don't have any symptoms of a urinary tract infection should stop. So within AMRIC and with our colleagues in acute and community, and we also liaised with infection specialists across acute and community, we developed position statements to take that recommendation forward, but also to do some further work on the urinary dipsticks and call out some further position statements to help people on the ground, I guess, supporting best practice. So the position statements is available as this document. It's available on antibioticprescribing.ie in the urinary section and also in the long-term care facility section. And I'll show you the link on how to get to the long-term care facility section at the end of the presentation. So in relation to that practice of dipping the urine of residents, be it on admission, on transfers, or regular intervals. So within the position statements, that's called out as if there's an absence of signs and symptoms of urinary tract infection, the use of dipstick urinalysis to assess for evidence of a UTI is not useful and should be avoided in people of all ages. Okay, so I think that calls it out pretty clear. And again, for those of you that have maybe been unsure as to the stance of this practice, I think that calls it out quite clear. Then the next relevant statements to the older persons or the residential care facility. If a person is suspected of having a urinary tract infection because they have signs and symptoms. So in those that are age 65 years and older, we are saying that the use of dipstick urinalysis in assessing for evidence of a UTI is not a useful guide to management and is not recommended. And that's also applicable to any person with an indwelling catheter. So regardless of their age, if they have an indwelling catheter, then the dipstick urinalysis is not helpful and should not be done. And the final piece that we would like to call out in the position statements as being relevant for your setting. If a person has completed an antibiotic course for a UTI, again, dipstick urinalysis has no role in assessing as to whether they have responded or not to the treatment of that urinary tract infection. Okay, so I suppose we'd like to provide some data and I suppose in some encouragement to say, yeah, some facilities have started taking this on board. So again, our CHO antimicrobial pharmacists are providing support to these individual HSE facilities that were audited. So they're being provided with this feedback and then education and being made aware of the supports that are available. So on the basis of that, these facilities are using dipsticks less and less. And I think when these facilities are using dipstick less and less, as we saw in those 2 facilities in CHO7, we're seeing that the antibiotic use is decreasing. And I'll show you a slide next with regards to that level of antibiotic use. But I would also like to call out, even prior to this work within the HSE older persons facilities, if we look to the HALT data, and again, I know a lot of you would have participated in the HALT studies. So back in the 2016 HALT study, it was found that, again, doing dipstick urinalysis in these residents that had no symptoms of UTIs was at 69% of facilities, when this PPS was carried out, that had reduced to 42% of facilities. So again, well done to those facilities that have actioned this already. It's great to see that improvement. And again, with this session and the various supports that are being put in place, we would hope that that would reduce to zero in the coming months. So this graph has been provided by our colleagues in community operations, and this is monthly key performance indicators in relation to the use of antibiotics, and it looks at other things in relation to healthcare associated infection and antimicrobial resistance. It's collected on a monthly basis since September 2021, and it's done by the HSE older persons residential care facilities. So the antibiotic related measures that they look at is the number of residents that have been on antibiotics at that point in time, and the number of those residents that are on prophylactic antibiotics. And this graph here refers to that overall number of percentage of residents that are on antibiotics. So the point prevalence study that I referred to, the data relating to that is what we're referring to as the baseline data. So you can see that's in the blue bars, and this is broken down for each of the CHOs, and then the national totals are at the end. So you can see that the baseline use of antibiotics in these facilities was a lot higher at the baseline, and over the last few months has reduced significantly again, and we would imagine that not using the dipsticks and various other educations and supports has contributed to this. And obviously when you take something away, so it's nice that it's possibly replaced by something else to support you in that diagnosis of a urinary tract infection in your residence. So a decision aid for the management of suspected urinary tract infection in older persons has been put in place. And again, this is available on antibioticprescribing.ie. Again, our colleagues in the CHO have been educating some of you on this, so you may already be very familiar with it, and you may well be actually using it now in your practice. So that is available on the website in the urinary section and also in the long-term care facility section. So Emer is going to take you through this decision aid now. Thanks, Emer.
Thank you. So yes, this decision aid is, I mean, we don't anticipate that you'll use it in the way that you might have previously used dipsticks. You won't likely to do this routinely or whatever, but I think if the key is to support you in feeling confident about suspecting urinary tract infections and gathering information that might be useful when you're calling for some support to get medical assistance or prescription for a patient who might have a urinary tract infection. And so rather than doing a dipstick, you would have this evaluation in front of you to help with that discussion. And so really the drive is that you will be comfortable with thinking about the signs and symptoms that a person might have rather than about the result of a bedside test. And so the idea of the decision aid is to steer you through those. It prompts you to think about other conditions that the person might have. And there we definitely get into territory that is beyond the simple management of infection, and I suppose points to the challenges of managing some of these symptoms. But that some of the symptoms that people have in the lower urinary tract and genital tract can be for other reasons, and some of those are set out here in the first page of the decision aid, and they include vulvovaginal atrophy, which are postmenopausal changes, urethritis, sexually transmitted infections, and prostatitis. And then I won't say in large lettering, but certainly in prominent lettering, there is the message that we've just been outlining to you, which is the reason or the rationale for not performing the urine dipstick. So that's sort of at the heading of the decision aid. The next part of the decision aid is about supporting the evaluation of the symptoms. So if we move on to the next slide, we can have a look at that.
Sorry, now should
That's
be
okay.
moving on. Because I think I've swapped to presenter view, and we've had to the slideshow. So yeah.
Thank you. So the next question, after thinking about whether the person might have some of those other non-infection syndromes, is does the person have an indwelling urinary catheter? And we know actually from that data collection in the HSE facilities that there is a sizable proportion of residents in residential care facilities who do have an indwelling urinary catheter. So the answer to this question might be yes in a good proportion of people. And you'll see there that the symptoms that you look for are slightly different in those who have and those who do not have an indwelling urinary catheter. And this is to support the symptoms that are important in those people. And so rather than stepping through them in a lot of detail, broadly they're looking for classic urinary tract infection symptoms. And if the resident has new onset dysuria on its own, or 2 or more of fever and a number of other urinary tract symptoms, then they might have the criteria for thinking that they might have a urinary tract infection. And then a prompt for you to check their vitals and think about what the next steps are. And we'll come to the next steps in a moment. If they do have a urinary tract infection, if they do have a urinary catheter in place, the symptoms are slightly different, and the fever is still there. There are some, but not so visible hematuria is the only other real lower urinary tract symptom. New suprapubic or flank pain is there, and obviously a fever and new onset or worsening delirium and debility. And I think this is probably the most challenging one of these symptoms for both categories, whether you have or don't have a urinary catheter in place. It's obviously important to make sure that the urinary catheter is not blocked, and that is one of the prompts there as well, considering the timing of the last exchange of catheter and whether it's worth pursuing a new change of catheter as part of the early management of somebody with these symptoms. And so this box really supports then, if the answer is yes or no in either of those categories, what the next steps are. So if a urinary tract infection seems unlikely based on the absence of symptoms or not having enough of the symptoms, then the boxes on the outside of this slide indicate the next steps, which are to consider other causes, and this is supported in the box at the bottom, in the yellow, ensuring that the patient is hydrated, and a period of monitoring, because while somebody may not have symptoms in the early stage of a urinary tract infection, somebody may not have all of the symptoms that are required. But a short period later, they may have evolved. And so that is important to consider, is that the patient would need to be reviewed again, the resident would need to be reviewed again. If, however, it turns out that they do have enough of the symptoms to meet the criteria, then urinary tract infection is likely. A urine culture should be sent if possible before antibiotics are given, and then antibiotics should be sought, and the input of a prescriber would be required at that point. And then there are next steps, as I mentioned, about obviously going into management of someone perhaps with a more severe illness who might require hospitalization, who might require a different antibiotic, who might require additional more invasive treatment and support. The box at the bottom supports thinking about other sites of infection and also other non-infection diagnoses, such as you'd be very familiar assessing your residents for pain, constipation, hydration issues. Are there medication issues? This is a group of people who are often on many different medications, and is there some issue with those? And has there been a recent change of environment? And again, you'll be more aware than me the importance of this in the well-being of your residents. So I think those are the main parts of the decision aid.
Thanks, Emer. I think that was really worthwhile, just kind of taking the time to go through that decision aid, because I think on immediate looking, it can be quite detailed and a lot of information. And I suppose what we're recommending is that people feel free to print this off and work through it with that individual resident and file it in their notes, or make it available as a poster on the ward, whatever suits the individual needs of the professional looking after the patient or the facility. So as I mentioned earlier, there is a lot of work going on in this area, and kindly some of the CHO antimicrobial pharmacists have shared some feedback that they've been getting as they've been rolling out this education and these supports. So again, I suppose some of this I think will resonate with you. So one statement from a nurse with regards to the dipstick urinalysis of those residents with no symptoms, so say for example on admission, was, "It's how we were trained." So I suppose our reply back to that again is, well, this is why we're doing this work, to support you and educate you in this up to date and this evolving situation, and to say that as we've heard in the presentation to date, is that the dipstick urinalysis of asymptomatic persons does no good and can actually lead ultimately to harm. And then a nurse in relation to a resident symptomatic of UTI, and what about the non-verbal resident? So again, just to highlight to you that in that decision aid, there is a section and a prompt on how to manage your non-verbal older person. I see a statement is coming, or a question on the chat box as to where this decision aid is. So it is available on antibioticprescribing.ie, and there's a link to it on the very front page of antibioticprescribing.ie, and I will show you in a slide or two, and it's available in the section for supports for long-term care facilities. And then the last statement that I've included here on this slide is from a prescriber, both in relation to the symptomatic resident and the asymptomatic resident, is that positive dipstick results add to pressure to prescribe. And I think that's a very important point to call out. So I suppose when you are confronted with that positive result, and as we said, we expect that to be the case, that most of your older persons will have that positive, but result. So it just makes the decision making so much more difficult. And when you're confronted with a positive result, you feel you have to do something about it. So if you don't do it at all, then you won't end up in that challenging situation. Moving on to the next slide, then again, just I suppose to emphasize the guidance and supports that are available to you. As I said, antibioticprescribing.ie is your go-to place. And there's a guideline on the diagnosis and management of urinary tract infection in residents that are non-catheterized, and there's a separate guideline for those that are catheterized. So it is that you've worked through the decision aid and you have come to the point that the resident may require antibiotics, then these are your guidelines to direct you as to what antibiotics are recommended. Also to highlight the HSE Land AMRIC e-learning module on the prevention and management of urinary tract infections is available, and we've had really great feedback, really positive feedback from people saying that they found it really useful, and especially as well that dipstick piece is covered in it as well. This is the section that I've been referring to on antibioticprescribing.ie. So this is the home page on the website, and this is the designated section for residential care facilities. So I'll move to the next slide and you'll see the resources that are available when you click on that tab. So there's a toolkit for the residential care facilities. So you can see the link to the decision aid is down there at the bottom, and the position statements for the dipstick are also there, and there are some other bits and pieces that we're not going to cover in the course of this webinar, but feel free to click in and have a look. So to summarize then, that urinary tract infection is a clinical diagnosis based on clinical signs and symptoms. It cannot be made by positive dipstick urinalysis in those greater than 65 years. And the recommendations really are for residents that are asymptomatic of UTI. So again, that on admission, on transfer, regular dipstick, that will no longer happen. And if patients are symptomatic of UTI, we would suggest that you go back to your facilities and have that discussion locally amongst the nursing and medical staff regarding how you're going to implement the national position statement on the dipstick urinalysis, and have a look at the decision aid and have a discussion about that and how you're going to implement that locally. So I know I've referred to these people throughout the course of the presentation. So again, these have done a huge amount of work in this area, and we'd very much like to acknowledge their contribution to all of this work. And that takes us then to any questions or comments. So a nice, short and sweet presentation on a Friday for you. I know one question did come in advance of the webinar, and that was in relation to vaginal estrogens and the use of it in postmenopausal women. And Emer, I just wanted to ask you what your thoughts were on that.
Yeah, it's certainly the case that some of the symptoms, that lower urinary tract or genital symptoms, if they're persistent, can be attributable to, or they can be mimicked, you know, urinary tract symptoms of that nature can be mimicked by the symptoms that accompany vulvovaginal atrophy seen after the menopause. My reading of the available literature is that it's not so clear as to whether the use of topical estrogens actually reduce urinary tract infections, but they certainly do reduce those symptoms in some women. So they may be worth considering with the resident who has those kind of lower symptoms. But I haven't seen a clear steer that they actually impact on incidence of infection per se, but they certainly may improve symptoms. But then you're getting very much outside of the comfort area that I work in terms of infection. So that's definitely a conversation for with the person's primary care doctor.
Thank you, Emer. No, there's there's a few bits and pieces coming through on the chat box, so I might just go through some of this.
So I suppose I'll mention a couple that I've answered. There was one about whether an MSU, a urinary sample, should be taken after antibiotics. So in the same way that a post antibiotic dipstick is not recommended, a post antibiotic MSU is not recommended either. Now there may be very unusual circumstances that is recommended by someone for very particular reasons. Perhaps I'm slightly racking my brain to think what they might be, but perhaps you have somebody who has had resistant organisms or something, but most want to repeat an MMP so some symptoms or evolving symptoms, I think that's when you would do another urine sample. But they certainly shouldn't be being done routinely after antibiotics. So I'd discourage that. The other question that I responded to was about hydration. And do you think it's recommended to hydrate for a day or two if someone has minimal symptoms? And I think that, yes, that's certainly a good strategy. If you don't have symptoms enough in the person that you're assessing to support the diagnosis of a urinary tract infection, considering other diagnoses is what we'd encourage, and a trial of hydration is certainly worth using. Dehydration in an elderly person can mimic a lot of syndromes of illness, and it's certainly a reasonable first step. You'd have to continue to monitor the resident, of course, for the development of new infection symptoms. As I mentioned earlier, that they might not all be present at the first assessment, but at a follow-up assessment, either the person has improved and there's no need for any further action other than your usual care, or they have developed new symptoms that might support the diagnosis of infection, and then it would be reasonable to proceed to considering antibiotics.
A question has come in relation to patients with very resistant infections that have had to be admitted for treatment, resistant to all oral antibiotic therapy and only sensitive to IV. Is there anything else we can be doing? So I suppose really that question refers to both good IPC practice and good antimicrobial stewardship practice. And I suppose it's never too late to do any of these things. So I suppose looking the toolkit that I referred to there, gives a nice summary on good antibiotic use. So again, it's prescribing according to the guidelines, regardless of what the infection it is, be it the urinary tract or the respiratory tract. One, I suppose, classification that we use in the community is talking about green antibiotics and red antibiotics. And if it's, I suppose, advocating for the use of the green antibiotics, which are seen as those safer agents and less likely to cause resistant infections, or less likely to cause antimicrobial resistance. So if we can steer towards those agents, that definitely will be of help, and obviously practicing good IPC practices.
There's a couple of questions. I'm just going to mention this one because I don't know the answer, but we'll see if I can find out, because it's not something I recommend. But is it safe to flush indwelling urinary catheter with citric acid for more than 2 times a week? I don't know, so I'm not going to pretend, but we'll see if we can find out and come back. There's another question. What's been recommended for residents with an indwelling catheter who does show symptoms, as the urine will definitely test positive? I think that's a good question because it really reflects what we've been saying. You're right, if they have symptoms, then we'd encourage you to use the decision aid. And if they have the symptoms that are on that decision aid, then it may well support that they have a urinary tract infection and they may need treatment. The dipstick won't help you one way or the other because, in other words, it's likely to be positive, and therefore it's not likely to reassure you by being negative, and it won't really add anything because it's likely to be positive whether they have an infection or not. So I think the focus is, if you have somebody who has an indwelling catheter, who has some symptoms that are of concern, use a decision aid to support you gathering that in a structured way, so that you can then advocate for them to receive antibiotics if that feels appropriate or if that seems appropriate.
There's a question there in terms of cranberry, as to whether it's effective to treat UTI or can be considered as prophylactic. As far as I know, and I'm happy to be corrected, but I think the evidence is quite weak in this area, and I don't think we would be supporting the use of cranberry either for treatment or prophylaxis.
Yep, and then there's a couple of questions about urine dipstick. When is it recommendable for doing urine dipstick over your 65s? Because we've really only talked about one indication for doing a urinalysis, which is its use in thinking about infections. And it's related to Margaret's question, which is what about an incidental positive dipstick? And yes, you're right, you may be doing admission testing for glucose, for example. I would say there are other indications for urine dipstick in over 65s, and they would be to do with the other findings that you can make on a dipstick. I think the main one is likely to be for glucose, and that's probably a useful one. And I suppose the other one might be for evaluating hematuria. Again, not in people with urinary catheters, of course, but for people without urinary catheters. I would say to Margaret's question about what about an incidental, so you're talking about someone who has had testing urinalysis perhaps for glucose and has found to have perhaps leukocytes or whatever. I would suggest that the decision aid would be used. If that person doesn't have symptoms, then I would recommend that you should be confident that that's not somebody who represents someone with active infection. Again, it might be somebody that you might mark up for a regular review to ensure that they didn't develop symptoms, but I would be comfortable that they would. It's an incidental finding. It's a bit like asymptomatic screening for anything. You have to be confident that what it means. And I would suggest that the decision aid will help you, because if they don't have symptoms, they don't meet the criteria for treatment, and therefore you can feel confident about that. I hope that helps.
There's a question in here on what's our view on giving residents prophylactic antibiotic therapy for urinary tract infection, and I think that's a really good question and really topical as well, because there is a lot of work being done in the area of prophylaxis for UTI. So we do have a section on the website for the management of recurrent UTIs in non-pregnant women. So I would direct you to that. And I suppose we've touched on various elements of that throughout the course of the presentation as well, is to consider alternative diagnoses in these people. Is it that they have a gynecological condition, or is it a dermatological issue that the patient is actually suffering with, and not in fact a urinary tract infection? So just to think about that. But also, if a patient is on prophylactic antibiotics, our recommendation, we have a guideline talking about stopping and reviewing these prophylactic antibiotics. And I think a really key point to get across today is that a person should not be continued in the long term on these antibiotics without review, and we would recommend a 3 to 6 monthly review of these prophylactic antibiotics for urinary tract infection. And it may be the case that there are the rare patient that may benefit from these. So if a patient is maybe having repeated admissions to the hospital because of severe urinary tract infections, then possibly they may benefit for it. But again, if they are started on it, that there is that defined review, and that the agent is stopped if it's not having any benefit. Or again, a lot of these long-term, if like any other medication, if they're used for quite a while, then you will see adverse effects in the patients, and especially nitrofurantoin, there are some very worrying adverse effects that can occur in terms of liver effects or lung effects. So they're very it's important to have awareness around that.
I don't see any more questions in my feed, but perhaps you have any more, Mary?
You're on the Q&A, Emer, are you?
Yes.
Yeah, and there's a few then coming in on the chat as well. But I think we've covered most of them.
Okay.
Yeah, I think so. So I think that's been very valuable discussion within both the chat and the Q&A, and thank you very much for your active participation on the webinar, because I think while you're asking the question, I think a lot of other people on the call will benefit from that discussion. So thank you, it's been great, and thank you, Emer.
Thank you, and thanks for your participation, and enjoy the rest of your lunch break.
Okay, thanks everyone. Bye now.